Assalamu alaikum. In this lecture, I will talk about diabetes mellitus. Normal glucose metabolism, the normal glucose balance is tightly controlled through a balance between glucose delivery and glucose uptake by peripheral tissue. There are two sources for glucose delivery. First, from the GIT through the oral uptake, and second source from the liver by a process of gluconeogenesis and glycogen lysis. Glycogen lysis means conversion of glycogen, stored glycogen in the liver, to glucose, and gluconeogenesis means conversion of non-carbohydrate sources into glucose. So there is blood sugar is tightly controlled through the balance between glucose delivery and glucose uptake by the peripheral tissue. Now, this process is maintained through two groups of hormone. First group responsible for downregulation of glucose, including insulin, amylin, and incretins. And second group of hormone responsible for upregulation of glucose, mean elevation of blood sugar when there is drop in the blood sugar, including glucagon, cortisol, and catecholamines. Insulin is a polypeptide hormone secreted from the endocrine part of the pancreas. You know, pancreas has exocrine function responsible for the secretion of digestive enzyme to the small intestine, and endocrine part composed of islets of small cell or called composed of beta cell and alpha cell, and the beta cell in the islets of Langerhans secrete the insulin, and the main source for insulin secretion is glucose level. After secretion of insulin, the main action of insulin is to facilitate entry of glucose to the tissue, particularly skeletal muscle. Also inhibit the glucose production by the liver through the inhibition of glycogen lysis and gluconeogenesis. Also, it inhibits lipolysis, so it is called anabolic hormone, promote protein and lipid synthesis. Other type of hormone that is responsible for regulation of blood sugar is incretin. Incretin, in fact, is a group of peptide hormone. The most important one is GLP, glucagon-like peptide. This group of polypeptide hormones secreted from the small intestine in response to the diet, in response to release of gastric juice to the small intestine. The action of incretin is first inhibition of appetite center in the brain, so the person stop eating, delay gastric emptying of gastric juice to the small intestine to reduce the absorption, and it promote secretion of insulin and inhibit secretion of glucagon. So the net action, the net effect of incretin is to down regulate blood sugar, to maintain blood sugar. Now, what is diabetes? Diabetes is a clinical syndrome characterized by hyperglycemia, which is the main metabolic abnormality in the diabetes, hyperglycemia, due to absolute or relative insulin deficiency. I mean, sometimes there's complete deficiency of insulin, sometimes relative deficiency in relation to the need of the body. But this is not only the problem. The major morbidity and mortality of diabetes result from subsequent development of the vascular and neuropathic complications. Okay. Regarding the epidemiology of diabetes, there are three facts about the epidemiology of diabetes. You have to know them. First, The disease is worldwide health problem. No area in the world, no population in the world escape from the disease. Invariable prevalence of over different countries, as you can see in this slide. For example, in Middle East, the prevalence is about 9.7% of the population, while in United States about 27%. 11%. Second point regarding the epidemiology of diabetes, that the disease, the problem, is not stable, but it's expanding problem. For example, the estimated number of diabetic patients in 2013 is about 380 million and expected to jump to about 600 million in 2035. So the problem is expanding, probably due to change in the lifestyle and diet habit of the population. The third point in the epidemiology of diabetes is that there is a large number of diabetic patients remain undiagnosed in the community because of mild symptom or lack of symptom, and it's expected to have the same number of diagnosed patients who remain undiagnosed in the community. So we need screening program to detect such patients. Diabetes can be classified into following types. The major type of diabetes are type 1 and type 2. Type 1 mean that type of diabetes that occur usually in children and adolescents, and it always need insulin for a treatment. While type 2 diabetes, that type of diabetes that occur usually in adult, and most of them can be controlled by oral antidiabetic agent. However, nowadays many children have type 2 diabetes, especially those with obesity, and many adult patients also have type 1 diabetes, so both can occur in any age. Other types are gestational diabetes and diabetes secondary to pancreatic disease or other endocrine disorder. Regarding the etiology and pathophysiology of diabetes, in type 1 diabetes, the underlying pathophysiology is absolute deficiency of insulin, meaning there is lack of insulin. This results from genetic susceptibility plus environmental factor, and most important factor is probably the viral infection like Coxsackie virus. This virus, if occur in genetically susceptible child, it can lead to formation of autoantibodies which attack beta cell in the islets of Langerhans and destroy them and lead to severe insulin deficiency and eventually diabetes. While in type 2 diabetes, there is two factors. First, there is insulin resistance, meaning there is failure of response of the tissue to insulin. And with time, there will be, initially this problem is compensated by oversecretion of insulin, but with time, because of exhaustion of beta cell, there will be also deficiency of insulin, relative deficiency. So there are two factors in type 2 diabetes. First, insulin resistance, and second, insulin deficiency, but not absolute deficiency of insulin. The predisposing factor for that include genetic susceptibility and other factors like diet habit, obesity, sedentary life, age, and history of gestational diabetes. All these factors increase susceptibility to insulin resistant and eventually to type 2 diabetes. Now, how patients with diabetes present to us? The classical symptoms of diabetes, which are well known even by lay people, are the triad of polyuria, nocturia, and thirst. Polyuria means increased frequency of micturition with increased amount of micturition. Nocturia means waking the patient at night for micturition because of increased diuresis. Other symptoms are tiredness, increased appetite with weight loss. This combination occurs particularly in diabetic patient when there is an increased appetite but the patient suffering from weight loss. Some patients in type 1 diabetes, if there is delay in the diagnosis, might present for first time with complication called diabetic ketoacidosis. And in type 2 diabetes, also patient might present for first time with complication including urinary tract infection, genital tract infection, or a neuropathy. For you as a dentist, the patient might present to you with periodontal disease, and this might be also as a complication of diabetes or might be the presenting feature of diabetes for an undiagnosed patient. For diagnosis of diabetes, we need one of the following investigation. Either fasting plasma glucose of more or equal to 126 mg per deciliter. Fasting means patient must be fasted for 8 hours, then check blood sugar. Or random blood sugar mean assessment of blood sugar 2 hours after meal of 200 mg per deciliter or more. Or hemoglobin A1C, glycated hemoglobin of 6.5% or more, and or positive oral glucose tolerance test. Usually we need more than one reading of different type to confirm diagnosis of diabetes. Normal blood sugar, of course, between 65 to 104 milligram per deciliter. In between result between 105 to 125 consider pre-diabetes, mean such patients are susceptible for diabetes in the future, so they need follow-up and change in their lifestyle. The lines of treatment of diabetes include lifestyle modification and anti-diabetic agent. Lifestyle modification include diet habit, certain diet regime, we'll talk about it, exercise, and weight reduction, particularly in overweight or in obese patient, because weight reduction will improve response of the tissue to the insulin. It means reduce insulin resistance. So it's a very important step in the management of diabetes. In addition to that, diabetic patient needs psychological support because diagnosis of diabetes is a trauma to most of the patients. So you have to support the patient, ensure the patient to ensure compliance of the patient with you and with his treatment. Education is very important step of management of diabetic patient with each visit of the patient to the doctor regarding the natural history of the disease, regarding the treatment, the diet habit, exercise, symptom of hyperglycemia and hypoglycemia. All this information must be educated, must be learned to the patient. We have large number of antidiabetic agents, but in summary, we can classify them into following groups. First group called insulin secretics, mean drugs that stimulate insulin secretion from beta cell, like sulfonylureas, most familiar one, dibeneclamide. Other group is insulin sensitizer. It means drugs that improve insulin sensitivity, improve response of the tissue to the insulin, like metformin, glucophage, and pioglitazone. Third group is incretin-based therapy, mean drug which act on incretin. As we said, incretin peptides that secreted from the small intestine and improve the glucose level by decrease gastric emptying by increase insulin secretion and decrease glucagon secretion. And this drug might act on the DPP4 enzyme that destroy incretin. So this drug prolong the effect of incretin, called DPP4 inhibitor, or act directly on incretin receptor and mimic the incretin, called GLP, glucagon-like peptide receptor and agonist, mean act like incretin. Fourth group called sodium glucose cotransporter inhibitor, like canagliflozin. This drug act on the renal tubule to prevent reabsorption of glucose by renal tubule, and that by increase glucose excretion by the kidney and eventually reduce blood sugar. And lastly, we have insulin, the main line of treatment in type 1 diabetes. Regarding the guidelines for treatment of type 2 diabetic patient, in summary, we have 4 steps. In the first step, we use metformin, single drug. The drug of choice was metformin. If the patient not respond, then we have to use 2 drugs, including metformin plus other 1 drug. If not respond, we use 3 drugs, including metformin plus other 2 drugs. And if the patient not respond, then we have to shift to intensive insulin regime. And you don't need details of that regimes. Regarding insulin classified into different groups according to the duration of insulin. We have short-acting insulin, which act for about 6 hours, intermediate-acting insulin, like anti-insulin, which act about 12 hours. طبعا lay people call short-acting insulin الانسولين الصافي، والintermediate insulin يسموه الانسولين الخابط. And we have long-acting insulin, a new generation of insulin, which act for about 24 hours, called basal insulin, like large insulin. الناس يسموه insulin طويل الأمد. And we have premix insulin, which composed a combination of short-acting and intermediate-acting insulin in different percentage, usually between 70% intermediate and 30% short-acting insulin. Insulin considered the only line of treatment in type 1 diabetes. There is no other choice. You have to use insulin in type 1 diabetes. Also used in type 2 diabetic patient who fail to respond to other antidiabetic agent. Insulin used in acute stressful situation, like during surgery or during trauma or severe infection, whatever the type of diabetes. And lastly, insulin also used in pregnancy, because most of oral antidiabetic agents are teratogenic except metformin. Insulin given by subcutaneous injection, either by certain syringe called insulin syringe, which has capacity of 1 ml, and each 1 ml contain 100 units of insulin. So each 0.1 ml deliver 10 units of insulin. Okay, so when you tell the patient you have to take 20 units, mana 0.2 ml of insulin. Or insulin can be given by a certain device called insulin pen. This device contain cartridge of insulin, contain caliper for adjustment of the dose of insulin. You can decide the dose of insulin, and a very narrow needle to deliver insulin. By this device, the patient can adjust the dose exactly, because just he adjusts the knob on certain dose, and then the pen they deliver the exact dose without need of syringe and aspiration and injection of the insulin. And also insulin can be given by insulin pump, which is an electronic device connected to the abdomen, and deliver insulin through an implanted subcutaneous needle. And also this device can be programmed to deliver insulin at a certain rate. But however, this device is expensive and need maintenance, so it is of limited use till now. Technique of injection of insulin very important because it must be given subcutaneously, not intradermally, to ensure absorption of insulin. So you have to educate the patient about technique of injection of insulin. For monitoring of diabetic patient, we have short-term monitoring by assessment of blood sugar at different time of the day using glucometer. This gives us idea about fluctuation in the blood sugar over the 24 hour. And we have long-term monitoring of diabetes through assessment of hemoglobin A1C, which give idea about the control of blood sugar over last 2 to 3 months. Glucometer is a simple electronic device with a certain kit, and by placing drop of blood, this will give result within minutes. So easy, used by most of the patients. Regarding surgery and diabetes, surgery is a stressful situation which can lead to a catabolic state by increase a counter-regulatory hormone including catecholamine and corticosteroid. So in undiagnosed patient or in poorly controlled diabetic patient, surgery can lead to acute decompensation, acute deterioration in the blood sugar, and this might precipitate diabetic ketoacidosis, especially in type 1 diabetes. In addition, poorly controlled diabetic patients usually have impaired phagocytic function, and this will eventually affect the healing of the surgical wounds. So we have to control the diabetic patient well before any surgery. In general, when we plan for surgery in diabetic patient, we have to assess his glycemic status, assess his control. Also, we have to assess associated morbidity like any cardiovascular problem or renal problem, which are common complications in diabetic patient, and then review the treatment. In general, if the patient well controlled had a plan for minor surgery, then we can keep him on the same treatment, just omit the dose of that day, of the day of the surgery. But if the patient exposed to major surgery or is poorly controlled, then we have to shift him to insulin and keep him on insulin for short period until patient become proof after surgery. Then we can return back to his original regime. This is the end of this lecture, and if you have any problem, also you can contact me. Thank you.